So our next session is on influenza, session number 2. And we are privileged to have as chair of that, Dr. Salah Al-Awadi. As I mentioned before, he is the chairman of the Middle East, Eurasia and Africa Influenza Stakeholders Network. He's the former director of communicable disease surveillance and control in Oman. And he is currently working as the communicable disease advisor in the Ministry of Health in Oman. And you can, there is plenty more information that you can see there to add to his credentials. So without spending too much more time, Dr. Salah Al-Awadi, please.
Thank you. Thank you so much, Kim. Do you hear me clearly? Right? Okay, great. Thank you so much, Kim. Well, good evening and good afternoon for others. And I would like to welcome, to pass my deep welcome to everybody. And I'm really delighted and privileged to welcome you all on the second session in our APACI respiratory disease workshop. If I may, I would like to a bit more introduce myself as Kim already did it. I'm Salah Al-Awadi. I'm a pediatrician and epidemiologist. I'm also the chairperson of the MENA-SN, which stands for, as Kim said clearly, Middle East, Eurasia, and Africa Influenza Stakeholder Network. This is a new association, has been established sometime in November 2019, and aiming to support and empower countries of the region as much as possible to protect their population against threats of influenza. In this session that we are going on today is going to be about influenza, and we will feature 3 keynote speakers who will deliver presentation on different aspects of influenza. And I believe we want to make this session as much as possible in terms of interactive as we possibly can. So at the end of the presentation will be followed by question and answers period. This, therefore, we would like to ask you all to post your questions and query as much as possible in the chat box, and I will pass them over to the speakers. And before I introduce our esteemed speakers, we have a polling question that you are going to see on the screen, and we are kindly requesting you to please to respond to the question. May I? Can you put the question is, have you been vaccinated against influenza in the last 12 months? Just respond yes or no. Great. Okay. Okay, great. So without further delay, may I remind our speaker that you will have 20 minutes for your talk. So what I'm going to do is I'm going to introduce our first speaker, who is Dr. Hanur Rashid. He is a senior research officer, National for Immunization Research and Surveillance, Kids Research, in the Children's Hospital at Westmead, Australia. He is also a clinical associate professor, discipline of child and adolescent health in University of Sydney. He is also co-lead in mass gathering medicine node in Sydney Institute for Infectious Diseases, University of Sydney. He is a counselor and honorary secretary in Australian College of Tropical Medicine, Townsville, Queensland, Australia. And it seems to be has a wide range of research interests, starting from mass gathering medicine, travel medicine, respiratory viruses, epidemiology, and vaccination. And he is going to talk around viral respiratory infection. Is influenza the only threat? Dr. Rashid, the floor is yours, please. Go ahead.
Thank you. Thank you, Dr. Salah, and thank you, Kim. Let me see, first of all. Can you see my slides, first of all?
Yes, yes, we could see them.
Well, I'm very
Just
privileged to speak
please,
before an audience like this.
could you
Sorry.
Dr. Rashid, could you enlarge
Yes.
it? Yeah, just click the.
Yeah,
No,
that's fine.
yeah, that's right. That's perfect.
Thank you.
Great.
So it's a great privilege to speak before an audience like this. So this was my actual initial topic, viral respiratory infections. Is influenza the only threat? As Dr. Salah said, that's fine. I shall cover this as well. But then actually I negotiated to speak on this, actually epidemiology and prevention of respiratory viral infections at mass gatherings. But don't worry, I will cover the topic anyway, both. Thank you. So just let me take you to the best classics, as I say, a very beautiful publication by Heikkinen and Järvinen from Finland. It was probably a seminar, actually, a year review published in the Lancet back in 2003. And it's one of their tables, the common causes of common cold, as you can see, the list of different viruses that cause common cold. And again, I want to differentiate one point here is that today we are not talking about common cold, we are talking about respiratory viral infections. But as you know, almost all respiratory viral infections present with common cold. So as you can see, rhinovirus is one of the commonest, the commonest cause, you can say, followed by corona, influenza, and others. And about 20 to 30%, we don't know. But then science is developing, as you can see, in the last 2 decades, we saw many new discoveries, HMPV in 2001, SARS-CoV-1, and NL63, again, another seasonal coronavirus, HKU. Both of these, one is NL means Netherlands because it was discovered in Netherlands, HKU that was discovered in Hong Kong. Both are coronaviruses. So human virus, MERS-CoV, and SARS-CoV-2. Now, a little bit about the seasonality of the respiratory viruses, as you can see, coronavirus, RSV, and influenza, they predominantly, for example, occurs in the winter season. So I'm talking about the Northern Hemisphere. This table is for the Northern Hemisphere. So beginning in November, December, it ends almost, it goes till, say, March, April in the Northern Hemisphere. Then is followed by rhinovirus, the next 3 or 4, up to 7 months. So now that's a little bit to answer the first question that I was posed, is influenza the only threat? I think the answer is no. Now, let me take you through the mass gathering. So it has got a beautiful definition given by World Health Organization, but just a gathering of about 1,000 people can make a mass gathering. But it's not all about the number of people, rather it's about whether this number of people strain healthcare. So the mass gatherings can be spontaneous. For example, as we can see, people stranded in the airport. Take as an example, Kabul airport. I'm sorry, I say it all sadness for the events that we saw in the last few days. So that's a mass gathering. And that also can be a planned gathering like FIFA, Olympic, Hajj. Now, despite the COVID pandemic, we saw several mass gatherings, and I'm going to show it to you. So this is a picture of Tokyo Olympic back in 1964. And this is a picture of Tokyo Olympic that happened just a few weeks ago. And there's a picture of Hajj before COVID, and there's a picture of Hajj after COVID. I think the difference, so here you can see only human heads. And here you can clearly see the floor, very beautiful marble floor. So, and that's Kumbh Mela. That's happened in April in Haridwar in India. And I just was looking for some data on Kumbh Mela, found this beautiful graph from The Economist. So I don't know if I can get rid of this. Sorry about that. Sorry. So as you can see here in the graph, so the Kumbh Mela started on the beginning of April. So with the Kumbh Mela, the surge of COVID due to the super spreading events in India went up. So there are other examples. Salt Lake in Salt Lake in the USA back in 2002, there was an influenza outbreak. World Youth Day here in Sydney in 2008, there are several outbreaks. I don't say several, but few outbreaks of influenza by different strains. Now we have done more work in this fair Hajj, which during a non-COVID year, approximately 2 to 3 million people attend, and people keep moving. So as you can see, people are now, for example, moving from one place to another during Hajj, and they ultimately come here in a city of tents in Mina. So this is the sleeping arrangement head to head. And also stay overnight in a place called Muzdalifah. They don't sleep there. I mean, just meditate, do prayers. And where humans stay, I mean, the pilgrims stay, adjacent to that, there is an area where the millions of animals, goats, sheep, and also some camels are brought. So think about Marskuvi. Climate of Mecca is mostly dry, a little bit of shower at the end of the year, November, December. Pilgrims who come here, majority of them well, some of them, I don't say majority, about 1/3 of them have different comorbidities, diabetes, obesity altogether. About 10% are smokers. And 1/4 of the pilgrims, overseas pilgrims, are older than 65 years. So pilgrims, essentially everyone, I mean, if I make this 9,700% actually, present with at least one respiratory symptom. And 60% of them suffer from influenza-like illness. So a combination of cough, sore throat, fever. And our French colleagues have done a very beautiful study. So they swabbed, irrespective of the symptoms, they swabbed 165 pilgrims before they depart, before they are boarding plane, and then they swabbed again during Hajj, and then they swabbed again before leaving Saudi Arabia. During this phase of the Hajj study was not very complete. As you can see, this color means some of them they could not swab in the middle. So that's why I've taken the data from this first, before and after. The before Hajj, 4.8% or close to 5% positive for at least one virus. At the end of Hajj, 11% were positive for at least one virus. And I know this percentage, but that percentage is maybe a bit biased because some people did not give. This was about 38%. Anyway, so what it means is that attendance of the mass gathering increased the risk by at least 2.3%. Now, here is some more beautiful data in a tabulated form that's done in 2009. My friend, Professor Ziad Memish, looked at the profile of the viruses. He took samples from pilgrims who arrived in Jeddah airport, and again when pilgrims are departing. So this actually not the same people's data. It's about 500 pilgrims randomly sampled here, about 2,000, about close to 3,000 pilgrims were sampled here. So as you can see, the profile is almost similar to what Heikkinen and Järvinen told in their wonderful review, Lancet review. Mostly it's rhinovirus, but the other viruses, influenza, H1N1, that's the pandemic strain, and all other different viruses are found here. Now, just to have an idea about its compared to what happened in the COVID era, I got a random manuscript, So this data is about healthcare workers, about 400 healthcare workers, symptomatic healthcare workers at a hospital in Manila are swabbed, symptomatic, they had symptoms. So to see what different viruses they have. So as you can see, again, the rhinovirus was the commonest one, followed by SARS-CoV-2 and also influenza. As you can see, 4 had influenza, 5 had COVID, and about 19 had rhino. And this is a very beautiful large study from New Zealand in the GP Sentinel services, actually done to see whether impact of COVID interventions, physical distancing, etc., made any difference to the pattern of respiratory viral infections in New Zealand. And it's a very cluttered and very busy table. I just make a simple comment here is the first of all, looking at the profile of the viruses, as you can see, rhino, influenza, enteroviruses, these are the same thing. What actually Heikkinen and Zarvinen told in their wonderful review. But what was very interesting is that this pre-lockdown or pre-COVID interventions, much higher compared to during and post-lockdown period. So the measures that were taken, distancing, etc., had an impact on the other respiratory viruses as well. So prevention of respiratory infections, as we know, we just broadly, divide into two categories: pharmaceutical and non-pharmaceutical. Pharmaceutical means vaccines and antivirals, and non-pharmaceutical means a lot of different things, including personal protective equipment, hand hygiene. Now, we evaluated this trivalent influenza vaccine at Hatch. So this is the red line is about the vaccination coverage. So as you can see, before 2007-8, actually, to be precise, before the pandemic of 2009, vaccine uptake was fairly low. Then it started going up, and then after the pandemic, a couple of years after the pandemic, it came to a plateau almost. Now the vaccination coverage at Hajj is about 80 to 90. Sorry, well, it ranges between 80 and 90. So as you can see in this paper, the vaccination uptake goes up, the influenza-like illness goes down. It was the highest there, and it was the lowest, the influenza-like illness. Vaccination rate falls, influenza-like illness goes up. So that's a very mirror image, actually, you can get. We also pulled the data on vaccine effectiveness. Again, trivalent vaccine effectiveness, and we found that actually, while individual studies don't show much effect, but when you pull it, vaccination seems to have some effects. And actually, overall vaccine effectiveness was about 43.4%. However, about up to one third of the vaccinated pilgrims had influenza. So we wanted to really understand why, despite receiving vaccination of the time, they had influenza. So we embarked on we did some sequencing of influenza virus. So the green ones, actually the vaccine strain. And the black ones are the circulating strains. As you can see that there is distances. So they're not always matching. I mean, at a molecular level, I mean. And also beautiful thing is that the strains that were circulating at Hatch predominantly came from all different parts of the world, including, for example, Europe, France, UK, and also their local Saudi Arabian and neighboring country strains, and also came from as far as Mali and Cameroon. And so that's about influenza vaccine. We don't have any precise data on quadrivalent influenza vaccine, but that could be a very interesting thing. And I think quadrivalent vaccine will give better protection. Now, coming to COVID vaccination, we don't have any data from any mass gathering. We know that in Tokyo Olympic, about 85% are vaccinated. That's from news, not from any published peer-reviewed data. And despite this, about 500 cases are reported among or attributable to Tokyo Olympic. But I then chose a few randomly selected, selected papers from Canada and UK, for example, just to understand what vaccination is doing. So this is from Canada. Test negative case control study. This adjusted and non-adjusted values have been presented. So let's focus on adjusted value. So these darker ones, these are single dose, and the yellowish ones are this about 2 dose vaccination. So as you can see, following 1 week after 2 doses, the vaccine effectiveness rose to close to 98%, I mean, about 100%, you can say. It's very good, mRNA vaccine. Now, from the UK, they found that even people among aged 70 and above, both mRNA and this is the AstraZeneca vaccine, i.e. adenovirus vector vaccine, both had almost about 60% effectiveness. about a month after vaccination. And a common question we often get whether it's effective against that. I think there will be more discussions in the coming sessions on this. There will be specific, but just because it's related to I've just covered here. Again, from the UK, mRNA vaccine was about 94% effective against Alpha variant, the local, and 88% against Delta variant. And that's published in New England Journal of Medicine just this last week. And AstraZeneca vaccine, about 75% protective against Alpha, 67% protective against Delta. So face mask we studied at the Hatch, to our knowledge, this is the largest face mask any study in the community setting. So we have done it in Hajj over 3 years, 2013 to 15, and about 7,000 pilgrims were recruited, and we did not find any effectiveness of face mask, neither again laboratory proven infection nor again respiratory clinical infection. So I looked at the systematic reviews on face masks, and there has been a number of publications, systematic reviews on effectiveness of face masks against any respiratory viral infection. So this one I chose because it's a very good journal and also internal medicine. And they said the randomized trials in community settings found probably no difference between mask, surgical mask versus no mask in the risk of influenza or influenza-like illness, but compliance was low. And they updated it because it was a living rapid review. They updated. This is the 6th review. Again, they continue to say the strength of the evidence remains low. However, community mask was possibly associated with decreased risk for SARS-CoV infection in observation studies. So based on that, we are asked to continue to use face masks. Now about the hand hygiene, is very popular at mass gatherings like Hajj. However, there may be some differences in terms of which hand hygiene procedure you use. Sanitizer is found to reduce the ARI events, while soap and water perhaps not. That's coming from a systematic review just published in BMJ Open. Now, evidence compendium, social distancing, etc. We have got our team have done a commission review by the Australian Department of Health, and we found that physical distancing, at that time we used to call it social distancing several years ago. Physical distancing is helpful actually, and I found that historically it is very much it was practiced. For example, in Arabian culture, Dr. Saleh will be able to confirm me. So is the Prophet of Islam. He said this: he was asked, what should we do if there is an epidemic? He said, if you hear of its spread, don't approach it. And if an epidemic happens in your land, don't leave it in order to run away from it. So that's a good thing I would like to suggest here. So the quarantine is a little bit of history, days back to 1377. It was practiced in Eastern Europe. And whether, my question, do everyone comply with these distancing measures, travel restrictions? So this is a beautiful picture of the head of the Olympic, actually, Thomas Bach. So Olympic managers, Olympic organizers, or Olympic attendees, so I'm not allowed to go beyond the Olympic village. But this gentleman, Thomas Bach, I don't criticize this, but it was in the social media, lots of discussions. He was found walking there. So they shared it. I think he's a senior executive. He's allowed to go that side. I totally agree, but just as a little fun. Now, in summary, we can say that mass gatherings amplify the risk of infections, and COVID poses a great risk. And preventive actions can include vaccination, distancing, and vaccination is the main option though, but protection may be a little bit slightly lower for some variants like the Delta variants. I'd like to thank a lot of my wonderful colleagues, and thank you. Any questions? Should I stop here, sir?
I was mute.
No, that's fine.
Okay, thank you so much again, Dr. Harun Rashid. Really appreciate for your excellent talk. And hopefully we're going to have a lot of questions from the colleague, and I'm looking forward to see them at the end of 3 talks. So our next speaker is Dr. Yvonne Hung, Professor Yvonne Hung Professor is currently, sorry if I may be mistaken pronouncing some of the places, is Ru Chien and Helen Lien endowed professor in health science, pedagogy, professor of medicine and assistant dean and chief of division of infectious disease in department of medicine in faculty of medicine in University of Hong Kong. And Professor Hung has published more than 250 international peer-reviewed original article, including in a number of these communicable diseases area published in a very superior and known journals. His research interests include influenza, COVID-19, other respiratory virus antiviral treatment, and others as well. So thank you so much for being here, Professor Ivan Hung, and he's going to talk about management of influenza. Professor, the floor is yours. Please go ahead.
Thank you, Dr. Awadi, for your very kind introduction. So in the next 20 minutes, I'm going to talk about management of influenza. Here's my disclosure. So just going through some definitions. As we know, seasonal influenza are those who circulate and cause disease in humans every year. That, of course, include the two flu A, H1 and H3, flu B, and also flu C. Pandemic influenza, of course, we are including those not previously circulating among humans. And of course, that include a lot of the H1, 1918, 1957, H2N2, 1968, H3, and of course, most recently, the swine flu, the 2009 H1. And lastly, of course, is the zoonotic or variant influenza that include all the avian influenza, the H5, the H7, and also the H9, and also the swine H3N2. So the problem, of course, we know that influenza poses a heavy burden to global health, and that, of course, causing a big problem every year. Before the COVID, we have at least 500,000 people dying from influenza or its complications. And just in Hong Kong, we have around 500 deaths every year due to influenza and its complication. And those who are at risk, of course, are those who are elderly, young children, patients with chronic illness. And of course, we're facing new threats every year because of the antigenic drift. And of course, the forever avian influenza threat from H5 and H7. The other problem, of course, is the antigenic mismatch due to these antigenic drift, and of course, the weaning protection of the current vaccine. So how serious is influenza? As we see from this slide, we know that every year, as we said, the mortality is around 0.1% and about 500,000 deaths a year. For the pandemic flu, swine flu, of course, again, is less than, fewer than 0.1%. Only, but higher, of course, are those who are relatively young, surprisingly, than 65 years old because of the suspected previous infection that those above the 65 may have had previous infection and have acquired certain antibody. For H5, it's about 60%, and H7 is around 32% in terms of mortality rate. However, due to the COVID-19, as we have talked about this earlier today at the AGM of the APACI, due to the COVID-19 effect, we are seeing that in many countries there are basically no seasonal influenza peak at all for the last year. As we see in Hong Kong here, that basically after the 2020, in the January and February season, which we saw a small peak of the H1N1, and then also another small peak of H3N2. Otherwise, for the entire last year and earlier 2021, this year, basically the seasonal influenza peak has been ablated, likely due to the infection control measures that have implemented of course, the social distancing, the surgical masking, and perhaps there might be some intrinsic effect of the COVID-19 virus that causing a disappearance of the seasonal influenza. Of course, we worry about when these infection control measures relax, whether there will be a big spike of the seasonal influenza with the very low antibody level currently circulating in the community. So just looking at the kinetics of the influenza A virus infection is that it's actually very similar to COVID-19 despite very short, much shortened period. Once you're infected, in fact, there are a very rapid viral replication. And of course, this followed by this occurrence of the symptoms and also a surge in terms of the cytokine, the interleukin-6. By the end of the week, most of the symptoms have disappeared. And then, of course, the viral replication has been controlled, and that the interleukin cytokine storm had already disappeared with a mounting of the IgG and IgG antibody. Nevertheless, if for those patients who have developed complication, the viral replication perhaps will be much more prolonged, and the cytokine reaction will probably last for a longer period of time. And of course, this includes those who have had developed a lower respiratory tract infection, where of course that there will be the local interferon and interleukin-6, there will be a rise in the cytokine. And of course, there will be some local restriction due to the local antibody response. However, if the virus is able to spread to the lower tract, there will be some basically lower tract response, where there will be the alveolar macrophages trying to engulf the influenza A virus or influenza virus. Nevertheless, there will be a subsequent response of cytokine surge of interferon, alpha and beta, and also interleukin-1 beta. And of course, this is also, there will be the memory T cells will be able to activate and hopefully stopping the spread of the virus to the lower tract. Nevertheless, there will be some local response due to the naive T cells response, and hence causing a so-called collateral damage together with the cytokine storm, causing a lower tract pneumonia as a result. So these are the pictures taken from a Filipino patient who unfortunately succumbed to the swine flu, and this patient developed a very severe cytokine storm and very severe consolidation of the lower tract. Despite intubation and ventilatory support, the patient unfortunately succumbed. And with the postmortem, basically showing that there's diffuse alveolar damage and also pulmonary vascular thrombosis, together with a very diffuse myocarditis and thrombosis in the splenic vessels. And it's these complications that we are trying to prevent by, of course, vaccinating the individuals, especially those who are at risk, and of course, trying to give an early antiviral treatment in order to reduce the viral replication and hence reducing the subsequent complication in these patients. And this is, of course, a study that was performed by Kelvin Toh and myself, where we look at comparing patients who have death or comparing those who have developed ARDS or death compared to mild disease. And of course, we basically see that those patients who have succumbed or developed ARDS, they have a very persistent high viral load, whereas those who are now diseased, the viral load quickly come down and being contained. And of course, those who develop ARDS and death have a persistently high cytokine dysregulation of interleukin-6 and interleukin-10 compared to those with mild disease where these inflammatory cytokines are quickly contained and with a corresponding drop in the viral load. So when should antiviral be given? Basically, according to the CDC recommendation, are those who are hospitalized, those who have severe complicated and progressive illness, those who are at risk of influenza complication, and also in outbreak setting. And currently, of course, there are currently in use are those with the neuraminidase inhibitors, which are responsible for blocking the release of the influenza virus, and of course include the oseltamivir, zanamivir, and peramivir. Previously, of course, there's the M2 ion channel blocker as well with the amantadine and the ramantadine. And of course, the convalescent plasma is very good in blocking the hemagglutination of the virus to the host cell. In terms of the amanitin and the ranitidine, is basically an M2 ion channel blocker that prevent the uncoating of the virus in the endosome. Unfortunately, most of the influenza virus nowadays are basically resistant to the amanitin, and hence rendering the amanitin basically useless in terms of treatment of influenza. And of course, these are looking at data from China and Hong Kong and rest of the world. Predominantly, the X3 and also the H1 is very much resistant to the amanitin. With regards to the neuraminidase inhibitors, of course, it's able to prevent the release of the virus from the host cell surface. Despite the resistance is increasing, it still remains active to the influenza virus. Nevertheless, if you look at the delay from symptom onset to antiviral treatment, the optimal period is within 48 hours from symptom onset to the neuraminidase inhibitors treatment. However, if you look at those who have ending up in ICU and those who have very severe disease, there is a delay from symptom onset to antiviral treatment. And as a result, rendering the oseltamivir basically have a very modest effect because of the delay in the treatment of using the neuraminidase inhibitors. Nevertheless, if you look at these studies by pulling all the data from various countries, and you look at basically those with early treatment within 2 days, you can see that basically the survival is very high, and basically the neuraminidase inhibitors have its optimal effect. However, if there's a delay of more than 5 days, you see that basically that the neuraminidase inhibitors are very much rendering useless, and there is a significantly high mortality as a result because of the delay in the use of the oseltamivir. The other problem that we are facing, of course, is the resistance to oseltamivir and zanamivir emerging during treatment, which we can see in this single case report in the New England Journal of Medicine, where the patient after about a week of treatment developed the H275Y resistance, and then changing to zanamivir, and then of course after like 2 weeks treatment, the patient developed I223R resistance as well. So is this resistance that are emerging posing a big problem to the treatment of neuraminidase inhibitors? So what do we have in hands? Of course, there are now new antivirals that are being available, and these are polymerase inhibitors that include the favipiravir, the pimodivir, and the baloxavir that are currently available. And of course, they target at different sites. The favipiravir targeting basically the PP1, and the pimodivir targeting at the PP2, and the baloxavir at basically at the PA site. If you look at this study performed in China, in Beijing, basically it looks at combining 2 studies together, and by using a combination of favipiravir together with oseltamivir versus oseltamivir, you're basically seeing that there is a significant difference in terms of clinical improvement by using the combination of favipiravir with oseltamivir. However, once it's taken into account by excluding those who have received the steroids, the difference is very much becomes insignificant. However, by just looking at in terms of the symptomatic improvement by using at the 7 categories scale, most patients who have been treated with a combination have a so-called lower scale score compared to those who received the monotherapy. And overall, the negative to viral load, the favipiravir oseltamivir is very much favorable by day 10, where 67.5% have rendering negative compared to 21.9% in those who just received the oseltamivir monotherapy. This is another study, of course, by using the pimodivir together with oseltamivir in a complicated seasonal influenza A, and again showing that by using the pimodivir 600 milligrams together with oseltamivir 75 milligrams, the viral load is very much significantly reduced compared to the others using a single treatment with either just pimodivir or just oseltamivir alone. And again, in terms of the cumulative incidence of the basically the clinical improvement, again, the combination treatment is much higher in terms of resolution of the symptoms. And another study, by looking at hospitalized adults, the OPAL study, again, showing similar results by using the combination treatment with pimodivir. And again, you're looking at the, however, in terms of the clinical presentation, the comparing with the between the those who have 72 hours or those who are 96 hours after onset of symptom, there are no significant difference between the two groups. And finally, of course, the baloxavir has been very promising. If you look at this CAPTON study, which using the treatment of uncomplicated influenza in adults, where a single oral therapy have been able to show that the median time to alleviation of symptom are very much quicker with the by using the baloxavir compared to just using the placebo, with 53.7 hours compared to 80.2 hours. And of course, the comparing to placebo and also the oseltamivir, basically the viral load reduction again is much more significantly quicker with the baloxavir compared to both the placebo and the oseltamivir. Nevertheless, there are of course early emergence of the resistance of the I38X of 9.7% to the endonucleoside, and thus rendering reduced susceptibility to these patients who develop the resistance. Another study, of course, more recently published in the Capstone 2, where we looked at the treatment of baloxavir in high-risk adults and adolescents, again showing similar studies, a result to the Capstone 1, and again showing that the median time to alleviation is much quicker compared to the placebo, and again the viral load reduction again is much more significantly better compared to both the oseltamivir and the baloxavir and also the placebo. Prophylaxis again is very effective in household against influenza, where there is basically just 1.9% of the family members developing the influenza compared to 13.6% to the placebo as using as a prophylaxis. And again, nevertheless, you do see some resistance emerging in the various family clusters as a result of the treatment that we have to watch out for. And perhaps a combination treatment of the baloxavir together with the oseltamivir may overcome this resistant problem. So the overall principle of antiviral treatment is early commencement and probably using a combination of therapy to increase the spectrum of activity and potency, leading to rapid viral load suppression and reducing subsequent complication and viral shedding. And again, antiviral combination can be used together with immunomodulators, including convalescent plasma or other NSAID therapy that may, or other repurposing antiviral drugs, like this study that we performed by using a combination of clarithromycin together with naproxen oseltamivir combination, showing that again the clinical improvement are much quicker in terms of the PSI score in those using a combination of oseltamivir, clarithromycin, naproxen compared to just using oseltamivir alone, and have a significantly better survival in those who have moderate to severe influenza infection. And again, by looking at the viral load suppression, again, much quicker, and also suppression of the resistance, again, is better with the triple combination. Another study looking at using celecoxib together with oseltamivir, showing that, again, there is a better improvement in the new score. Nevertheless, the viral load suppression are not as significant compared to the triple therapy in the previous study. Nevertheless, the viral cytokine suppression in interleukin 6 and interleukin 10 are significantly better by using this combination. Another study that we published early on during the swine flu in the CID is by using a basically convalescent plasma therapy in severe influenza, and again showing that there's a better survival in the treatment group of a basically 34.8% reduction in terms of mortality by using the convalescent plasma compared to the control group. And similar study by using a fractionated hyperimmune IVIG from the convalescent plasma, showing similar results with a better survival and also with a better suppression of both the viral load and the cytokine reaction. This, of course, have been subsequently proven in a multi-centered trial by John Bagel's group, and of course, again, showing that there is a better survival in those who treated with the immune plasma of just 2% compared to 10% in those who in the control group. And finally, of course, we have to talk about the ECMO, which is very important in the management of severe influenza that will allow us by supporting the patients and allowing basically the cytokine to subside and allowing time for the antiviral together with the plasma therapy to work in patients with severe influenza. And again, in this study showing that who have been treated with ECMO support have a far better survival compared to the non-ECMO supported patients. So in conclusion, there is very much research needed for pandemic preparedness and of course organizing clinical trials by using both repurposing drugs together with, of course, the novel antiviral therapy that could be used. And of course, currently there are limited effect with the current neuraminidase inhibitors because of the emergence of resistance and of course the timing, the limited in the optimal timing. So it's promising result with the new preliminaries inhibitors that perhaps will work together better as a combination together with other antiviral drugs, for example, oseltamivir, and also other anti-inflammatory therapy together with convalescent plasma that will be effective in the treatment of severe influenza. And with this, I would like to end my talk and thank you for your very kind attention. Thank you.
Thank you. Thank you very much, Professor Hang, for very, very interesting and updating us on management of influenza. Very, very interesting to hear, though, a lot of updates in around that area. So our next speaker is going to be a Professor Minna Durusu Tanriova. She is a professor of internal medicine in Hacettepe University Faculty of Medicine. And just to give you more detail about her, she graduated from Hacettepe University Faculty of Medicine in 2000 and finished her residency training in internal medicine in 2005. And she has been work in the same hospital as co-chief. University of Oncology and Ecology in the same hospital and quality control. In addition to that, she has been involved in a number of these global activity, including Global Influenza Hospital Surveillance Network Project as an investigator and site coordinator, and participate in a number of these interesting sub-investigation in the phase 3 clinical trial of COVID vaccine available in Turkey and has been published in one of the very superior journal. And she has also been appointed as a primary investigator of the phase 3 clinical trial of Turcovac and inactivated COVID-19 vaccine. Welcome, Professor Minna, and thank you so much. And she is going to talk about rationale and benefits of flu influenza vaccination in priority groups. Welcome. Go ahead, Professor Minna. Go ahead, please.
Good afternoon or good evening, dear colleagues. So thank you very much for inviting me to this important conference. So I'm Minna Durusu Tanriova from Hacettepe University, Ankara, Turkey. I'm a professor of internal medicine and my academic area of interest is influenza and adult vaccination. And today I will be talking about the rationale and the benefits of flu vaccination in priority groups. So while getting prepared for this presentation, I have asked myself this question: what does flu mean to me? So the first word that came up into my mind was suffering, because flu is not a simple infection, but it's a disease with multiple complications, and suffering is there mainly for people with comorbidities. So this is a photograph from the times that I have been consulting the acute medical unit of my hospital. And this lady is around her 60s, and she has diabetes, she has chronic obstructive pulmonary disease, obesity and hyperventilation. And after a flu infection attack, she couldn't recover. So this was days after she was infected, and she was still in the hospital. So this is suffering for the patient, and this is also suffering for the healthcare team and the healthcare system. So flu has many, many impacts on both personal level, on the community level, and on the healthcare system level. So just to summarize you a little bit of what the burden of flu is, let us look at the incidence. So this is the data from the Global Burden of Disease 2017. And as you see, the incidence of flu is especially high in our region. So when you look at the data from India, you can see that just in 1 year, there have been around 26,000 deaths from flu, and there have been around 600,000 hospitalizations, and there have been around 14 million episodes. So you can see the burden of the infection on the healthcare systems. And when we look at the mortality, we can see that this is the global burden of flu mortality, just a very important study from John Paget and colleagues. So you can see that there have been around 400,000 deaths, respiratory deaths associated with influenza globally each year. And the mortality rate is especially high among people over 65 years of age. And when we look at the risk factors, aside from the age, higher baseline respiratory mortality, lower access to healthcare, and the circulating strain like the H1N1 pandemic 09 subtype have been delineated as risk factors for increased mortality even below 65 years of age. But just not only talk about the morbidity and mortality, because flu has lots of things to do beyond mortality and morbidity. Let us talk about antimicrobial resistance, because we know that bacterial co-infections are very, very frequent, up to 65% in adult influenza cohorts. And this brings together the antimicrobial resistance and also the functional decline. Just remember the lady that I've shown the picture of her a few minutes ago. So this lady will never revert back to her basal functional status before she was admitted to the hospital, especially in elderly people, in people with comorbidities. The functional decline is so rapid and so severe. I'm not talking about the costs here, but we know that at both micro economical level, meaning the person and the family, and at the macroeconomic level, meaning the healthcare systems, flu has a huge impact. And also do not forget that there is huge regional variation driven by healthcare and socioeconomic development. So in the region that we are living in, we have a high burden of chronic diseases. We have mass gatherings, so viruses are circulating among pilgrims. We have a disrupted primary healthcare system, and vaccine availability is usually low in many countries. So when we're talking about the priority groups, just I would like to emphasize that priority groups include the people who are at increased medical risk, but also include those who are very, very important for the sustainability of the social system of the countries. So these are people who are elderly, these are people with chronic medical conditions, pregnant women and children who have the highest medical risk. But aside from them, we have other groups who are recommended for immunization, like the healthcare personnel, like people working in the essential services, like military members, veterinarians, poultry workers, and so on and so forth. So WHO revised its recommendations in 2012 and just put the pregnant women at the highest priority for the flu vaccine, and we will talk in a minute why. And in the second priority group is the people who have medical risk factors and who have occupational prioritization to contract flu. But of course, everything has changed with the pandemic. So the WHO recommendations during the COVID-19 pandemic is a little bit revised. So in this case, starting from 2020, the highest priority is the healthcare workers and the older adults who have the highest risk of contracting COVID-19 and who have the highest risk of having untoward effects due to the disease. And we need to protect the healthcare workers because we need that healthcare force during the pandemic. Indian national authorities also have some recommendations. NGOs and national authorities of India recommend the flu vaccination. So this is the practice guideline from 2019 from the Indian Chest Society and National College of Chest Physicians of India. And this collaboration recommends flu for all high-risk groups as per the definition of the Ministry of Health and Family Welfare. And they also put, of course, an emphasis on people with chronic respiratory diseases. And they say that people with asthma, COPD, bronchiectasis, interstitial lung disease, and chronic smokers, and this is so important that because we have a very high prevalence of smoking in this region, are recommended flu vaccine every year. Also, the Association of Physicians of India recommend flu vaccination for all elderly people and for all those non-elderly who are at increased risk, again, every year, every season. And there's a very recent recommendation for the children. So the Indian Academy of Pediatrics recommends an inactivated influenza vaccine for all children older than 6 months, and stating that a uniform dosing of 15 micrograms is feasible. We do not need to give low doses. So a uniform dosing is recommended for all people older than 6 months of age. So there are the recommendations. We know the burden of flu, but we really do need to know the reasons why we should vaccinate the priority groups, because we have many, many vaccine hesitant people around, and we may be able to answer their questions, their question marks in their minds. So let's start with the healthcare workers. So we know that unvaccinated healthcare workers are prone to occupational influenza, and once they contract influenza, this causes a loss of workforce. And also we know that the unvaccinated healthcare workers are a major source for nosocomial influenza and infecting other colleagues, other healthcare workers. So this is very well demonstrated in many, many studies. So we know that when we vaccinate the healthcare providers, especially working in the high-risk settings like long-term healthcare settings, giving care to the elderly people, vaccinating the healthcare workers may have very, very positive impacts on the health of the people that they care for. So in this study, they have compared two cohorts in which there was a 70% of vaccination coverage rate among the healthcare providers compared to a 32% vaccination coverage rate. And what they have found is that the mortality rate among the elderly was less, 20% less in the highly vaccinated cohort, and influenza-like disease were 31% less frequent among the elderly residents. Of course, there was a reduction in the absenteeism. So there are many, many studies that outline the importance of vaccinating the healthcare workers, not only to protect themselves, but also to protect the ones who they care for. We know that elderly are at the highest risk of having untoward effects, complications, and mortality associated with the influenza infection. And this is a very recent study from Australia, involving many, many seasons to estimate the mean annual influenza-associated excess respiratory mortality and hospitalization rate. And what they have found is that the annual influenza-associated excess respiratory mortality is 2.6 per 100,000 population in general, whereas it is more than 15 times in the adults aged 75 years of age. So this also, of course, has impact on the hospitalization rate. And as you see that people aged over 75 years have a very high hospitalization rate when compared to the general population. So we know that elderly are very much affected from influenza. Actually, not only influenza, but also other respiratory viruses have a great impact on the elderly. So this is the data from our global influenza surveillance network cohort. So just let me translate what it is here. When you have the data, when you prospectively follow up people who have been admitted to the hospital with influenza-like illness, if you just focus on the data of the elderly over 65 years of age, you can see that 1/4 of these people, here you see, they require mechanical ventilation. Nearly half of them are required to be admitted to the intensive care unit, and 1/3 of them die in the hospital. So I think this is huge. But we know that, of course, not all the viral infections are influenza. 20% of these infections were due to influenza. So we know that influenza is a preventable disease by vaccine. Even though we cannot prevent the infection, we can prevent the untoward outcomes. So why not prevent what can be prevented? Here you see the huge impact of the infection on the elderly. And we now know that the increasing elderly population in our communities, increasing frailty due to comorbid diseases and aging, have a huge impact on our societies. So vaccination decreases the risk of death, decreases risk of pneumonia and frailty due to influenza in the older population. So I love this phrase a lot because I think it translates into what we're living today. So people may worry less about dying prematurely of infectious disease, but more about the risk of a prolonged period of ill health in old age. So when an elderly patient is admitted to the hospital because of influenza, even though he or she is just admitted by walking, this person is at the very highest risk of being bedridden at the end of that episode. So influenza vaccination has many things to do with the quality of life of these patients. And coming to the pregnant women, we know that the pregnant women is at the highest priority, and this has been consolidated after the 2009 pandemic. And we know that the relative risk of hospitalization with severe influenza is about 8 times higher than that of non-pregnant women of reproductive age or the same age group. And the risk of influenza-related hospitalization is 7 times higher. And unfortunately, 6% of the patients who were hospitalized or death in the 2009 H1N1 pandemic were pregnant women. And we know that there are many untoward effects for the fetus, and influenza infection causes fetal growth restriction, fetal distress, fetal anomaly, fetal mortality, preterm delivery, and also have some untoward effects for the infant, like the low birth weight and the requirement of the pediatric intensive care and neonatal death, and so on and so forth. So influenza, getting an influenza infection for a pregnant woman means a lot. So what can we do? What can we achieve by vaccinating these pregnant women? There are, again, lots of good data around, and just to give you some examples, vaccinating pregnant women with the flu vaccine decreases the risk of respiratory tract infection by 36%, decreases the laboratory-based diagnosed influenza about 50%, and decreases the hospitalization due to influenza in babies younger than 6 months by 91%. So this is huge, because while vaccinating the mother, we not only vaccinate her, but we also protect, immunize the child to be born until he or she develops his or her own immunity. And just I would like to express something, because as we know, there was a very low influenza season in the recent flu season, and this means that millions of people are now prone to influenza because they did not contracted influenza in the last 2 years maybe. So this upcoming season may be a very, very high influenza season. And the absence of the seasonal influenza activity during the 2020-21 season might have specific implications for infants in the upcoming season. So please just be aware of this and vaccinate your pregnant patients. Children need that vaccine because vaccinating children with the flu vaccine provides direct protection from influenza and associated complications like pneumonia and acute otitis media, and also provides indirect protection by lowering flu transmission from children to the adults to frail elderly. And it has been shown that vaccination of only the half of the children in 2 to 18 years of age may decrease influenza-associated morbidity and mortality. So by reaching a vaccine coverage rate of 50% among children may have huge impacts in the whole population. And coming to the other chronic medical diseases which constitute risk factors, we know that patients with diabetes mellitus have increased risk for immunosuppressive effects of hyperglycemia, increased susceptibility to specific infections, and there are many, many chronic diseases accompanying diabetes, and also diabetic patients have decreased pulmonary functions due to degenerative processes, which all increase the risk of influenza and associated infections. And just keep in mind that many type 2 diabetes patients are also obese, and obesity is an independent risk factor for severe disease and death in influenza because it induces an inflammatory state, and this increases the length of stay in intensive care unit, leads to an extensive and non-stoppable viral replication, and this increases morbidity and mortality. So diabetic patients are increased risk of influenza and related complications. And this is a study from our region, and you can see that diabetes alone by itself increases the risk of death around 7.5 times when compared to other matched people when they contract influenza infection. And you can see the survival curve among the diabetics and patients with no diabetes. So diabetic patients have a very lower, very worse survival curve when compared to those without diabetes. So what happens when we vaccinate people with diabetes mellitus with influenza vaccine? So they really benefit from it, not only in terms of mortality admission, but also in terms of decreasing risk of stroke, decreasing risk of heart failure, and decreasing risk of all-cause mortality. And here you can see the relative risks attained with vaccinating these people. And also keep in mind that diabetic patients have many, many accompanying cardiovascular diseases, and cardiovascular diseases by themselves are a major source of morbidity and mortality. And we know that influenza infection increases the risk of cardiovascular diseases by nearly 6 times in the risk period. The most risky, the risky period is the first 1 week around the infection. So when you vaccinate people with influenza vaccine, you can see that also the incidence of the acute ischemic heart diseases and acute heart failure in adults are decreased. So there is a very hot debate now. Can we use flu vaccine as a tool for cardiovascular disease prevention, just like we use statins, just like we offer smoking cessation? And there are many, many studies ahead to show whether we will benefit from the flu vaccine as a tool for cardiovascular disease prevention. And coming to the patients with chronic obstructive lung disease, so we have a very high prevalence of COPD in India, in the MENA ASEAN region. So we can already say that frequent exacerbations lead to lower quality of life and greater decline in health status, and just brings a greater likelihood of becoming housebound for these people. And influenza is a very important cause of COPD exacerbation. And we know that influenza positive patients have a very higher crude mortality rate when compared, and a higher critical illness rate when compared to influenza negative patients among the chronic obstructive lung diseases group. And this risk factors for mortality in influenza positive patients are already doubled or tripled when the patient has an underlying cardiac morbidity or using oxygen. So in advanced cases of COPD, influenza infection has a greater impact. So what happens if you vaccinate people with chronic obstructive lung disease? So you can see a nearly 40% reduction in influenza-related hospitalization. So this is not just the hospitalization, but you can see the same amount of decrease in the respiratory events and all-cause mortality, and the relative risk of death in the influenza season is really decreased when you vaccinate these people. And the maximum protection is documented in those with severe, at the severe stages of chronic obstructive lung disease. So here you see mean vaccine effectiveness of 67% all over in the incidence of acute respiratory infection and acute exacerbations of COPD. But when you look at the severe COPD patient population, this vaccine benefits are much more increased. So let me conclude with this, and I can say that suffering from influenza can be prevented by vaccines. So vaccines are not only preventing the infection, but just keep in mind that they prevent the morbidity, mortality, functional decline, and the suffering with influenza can be prevented with the vaccines. And I would like to thank all of my colleagues working with me, and for all the NGOs working to build a better future for people by advocating influenza vaccination. Thank you very much, and I will be happy to answer your questions.
Am I right now? Okay.
Yes.
Have you heard me before, or just I need to repeat that again?
No, we did not hear, but we understand what you are saying.
No, I'd like, first of all, just to thank Minna for the great presentation, and really, I'm sure that everybody has really benefited in summarizing the rationale and benefit of influenza vaccination priority group. Thank you so much, Professor, and thank you again so much, Dr. Rashid, for the presentation. So let us see the responses. So it seems to be not bad. We're having 60% that they say yes, they have taken. We're still having another 40%, unfortunately, were not taking the vaccines, and depending on the ages of the participants. But this is still not bad. But we hope but after this presentation, and maybe in the future when you do the same exercise, we will reach much higher, and we were able to convince everybody that the vaccination, influenza vaccination, is very important. Thank you so much for showing it. Unless somebody would like to, Professor Minna and Dr. Rashid, would like to comment on the slide. If you have anything, please, by all means. We're missing Professor Hank. He has already left. Please, you'd like to comment on this? Please.
Yeah, I mean, no comment. Just I would like to thank the organizers. This is a really wonderful occasion to share, and then, yeah, it must be. Would like to continue, but at a personal level, I just have an apology that it's a bit late here. I'll be leaving, but I'll join tomorrow, hopefully. Thank you.
Oh, so you're leaving now. You're leaving now.
I mean, I can. If there are questions, I can take. Can stay.
I haven't seen any question from the
That's
chat
fine.
box.
If there is
unfortunately. I haven't seen anything. Let me just raise a few questions, and any of the panel could really. My question for you, Dr. Harun Rashid, is I was really interested to see that, we are really focused a lot on influenza, and we keep forgetting about other profile of viruses that as many could be as important as influenza, and to see the rhinovirus is still one of the highest. What would be the public health implication having a knowledge, because there's no vaccine for that so far? How could we really tackle it? And since we have that knowledge that there are other viruses like rhinovirus that really cause a lot of burden, maybe causing a lot of mortality as well. Please go ahead.
Well, thank you very much. I mean, look, the rhinovirus, as the name suggests, it just mostly upper respiratory. Predominantly, it doesn't go down the trachea, but it does go very rarely in, especially very elderly population. So there has been some reports of even fatalities among elderly in people in residential care facilities to die from rhinovirus infection. So the first question here is that it's generally mild. It doesn't affect seriously. There has been some interventions. I think if Professor Ivan was with us, he could tell us. I mean, there has been a lot of work to, in terms of vaccination and particularly antiviral drugs. But what was found is that, the antiviral drugs against rhinovirus, it's not very effective. Overall, the people recover. In our country, we call this that it will take either 1 week or 7 days. So it's all the same, This is a common cold. Common cold is one of the commonest cause of common cold. So it generally, most of the people will heal very quickly, will recover. But, especially, so I think the public health, your question in terms of public health intervention is that we have to be particularly careful about the too elderly people, especially those who are in the nursing homes. I think interventions like hand hygiene, distancing, and perhaps if somebody has got flu-like illness, use of these personal protective equipments could be very useful. And also, it is very important to ensure that they are vaccinated, as Professor Mine very wonderfully discussed. The role of vaccine, I think. So once you are almost, sure that you are protected against some of these viruses, so the other one, rhino, is left, for instance, against which we don't have. So other interventions perhaps would complement. Yeah, thank you. That's my feeling.
Okay. May I, if there's one question for you as well, but if I'll go to Professor Minna, and then I'll come back, if you don't mind. Just gonna take a few seconds, if you don't mind.
Is it for me? The flu vaccine should be
yes.
In the future?
I think this is, yeah. If I may go to Professor Minna. Well, Professor Minna, you have very well elaborated to us, the disease burden among high risk and priority groups. Very well. I mean, everybody understands, everybody sees how bad is influenza among those groups. But even though we don't see the influenza uptake up to the standard that we're expecting, so in your opinion, what can we do? Because this is the disease that do cause high mortality and morbidity as well, huge morbidity, despite of maybe this is quite exceptional now because of the COVID. But sooner or later, we're going to go back to the same scenario. What do you think? What do you have in your mind? Why this is happening? Why the vaccination uptake, despite of that, is still not to the standard that we're expecting? Over.
Yeah, Professor. So, Dr. Salah, thank you for this question. We may speak on this for many hours, actually.
Yeah.
So, yeah, there are many barriers against reaching the high vaccination coverage rates. So, actually, we do need some regional, person-specific interventions in order to reach our targets. So I think one of the major obstacles is the healthcare workers themselves, because people really do trust in the healthcare workers. And if they see that the healthcare worker isn't vaccinated as well, people will never accept the vaccine. So the role modeling of the healthcare workers, so this may depend on the culture of the country, the region. It may be the pharmacist, it may be the doctor, it may be the midwife who is on the field. It's very important. So when one of your patients just asks you, should I get the flu jab? And you say yes, the next question will definitely be, did you take it? So when I tell my patients that me and all of my children, my family gets the flu vaccine, then this really builds the confidence in the vaccine, and the patient readily accepts it. So
Absolutely.
The first thing is, I think we have the role modeling and the acceptance from the healthcare workers. So the data is actually out there. And even during the pandemic time in 2019, the vaccine coverage rate for the pandemic influenza vaccine among the healthcare workers in Turkey was only 15%, 15%. So how can you achieve a high vaccine coverage rate when the doctors, the nurses do not get the vaccine themselves? So this is the first thing. And the other thing is the misinformation, the disinformation, and the lack of information. So people really do not know what influenza is about. They just think that it's just a simple upper respiratory tract disease like the common cold, and they do not think that it's a serious infection that may end up in serious complications. So we should talk about it. We should give examples of patients like the lady I have presented to you. So we should tell people what kind of a suffering it may end up with. So I think this is important. And the most, I think the hardest part is to combat with the disinformation. So disinformation is a type of information which is on purpose wrong, and just it's just disseminates very, very rapidly among people. So we need the support of the social scientists. We need to understand the vaccine behavior, and we need to find some targeted solutions. So there was a statement in one of the manuscripts, so I like it very much. So you cannot compare the vaccine behavior of a lady living in Africa who needs to walk for 2 kilometers to take the vaccine and a stakeholder just sitting in the WHO conference room in Geneva. So you may find, you may really need to find some specific solutions for each of them.
Okay, I have two quick questions, and this is for both Dr. Harun Rashid and you. Do you feel flu vaccine should be nasal only in the future? I don't know, maybe this is...
Can I just say a few words about this? Look,
please.
We used to have a flu, nasal flu vaccine actually. That's a live virus vaccine. So as you know, with any live virus vaccine, there are some problems, especially if it's a live virus going through the nose, through which actually, if you look at the transmission of influenza goes through nose or eyes or respiratory tract. So you're putting that here. So there are some concerns about this. Generally, these children who received this live attenuated vaccine, they had some adverse, more like wheeze, for example. I don't say bronchial asthma, but wheeze is more common. A good proportion of them used to have wheeze. There's one concern. The other concern was also more theoretical, is this more reassortant escape mutants type of thing that was more to do with the genomics, for example. But so the question here is, ultimately in most countries it's not used. It was very popular in I think Russia, also in the USA for some time. I don't know if he's using. We didn't use them. But the question here is, the answer here, I would like to say, is that there will be a better platform. For example, in Australia, we are working on nano patch. Just a patch you will put on your skin, like contraceptive, patches. So that might come, I don't know, anytime in the decade. And also lots of works actually going on. So to answer this question, actually it's already existing, the nasal vaccine, current live attenuated vaccine. I don't know if the question the doctor was asking about the live or, non-living vaccine, but the nasal live vaccine was available, for instance, but not now. Yeah, thanks. Any second question?
Great. Okay. This is a question from Dr. Rouhani. When influenza vaccination should become a national policy in the tropic countries? Anybody, Professor Minna or Dr. Rashid?
It's true that the flu vaccine is not a part of the national vaccination policy in many of the countries in the region that we are living in. So of course it should be a priority, and it first of all needs a policy. So if you do not have the policy, then it's the vaccine availability, the targeted solutions, they will all be harder to find. But just keep in mind that the national policy is not enough by itself. It needs much more effort in the field, in the micro level. So I cannot comment on the tropical countries, but I know that many of the countries in this region lack the national policy. So of course, it's a huge must, I think, to prioritize influenza vaccination.
Okay, great. I think the time is over. If I may, I would like to convey a profound appreciation to the speakers, Dr. Harun Rashid, Dr. Minna, and Professor Hang. Oh, unfortunately, he's not around. And for being here and for all these amazing and excellent presentation that's really adding a lot on top of what we know in the area of influenza. Thank you so much. And I'd like to thank the audience for being here as well, and wish you the best and be safe. Kim, the floor is yours. Thank you. Thank you.
Thank you.
Thank you.
Thank you very much. That was wonderful. Some really good discussion there. And so it reminds us why influenza is so important in this world of coronavirus. You know, it's easy to forget about influenza, even though there's very little influenza around. It's so important. And you know, the challenges of vaccination coverage in this particular environment, and of course, you know, talking about the lack of information and of course misinformation. While it's significant in relation to influenza, it actually impacts on all of the things that we've been talking about over this afternoon. So look, thank you everyone. I really have